Alan, I'm going to let you take the lead on the regorafenib story and dosing and managing in clinic. I'll just sort of set you up by saying, you know, this has matured now. We've gotten more comfort with the medicine, and we've got some strategies that we all use. So share yours.
Right.
If you don't mind.
So of course the issue with regorafenib is what dose do we use and how well tolerated is it, and if it's similar to sorafenib, which is almost the exact same drug. I tend to err on the side of under-treating patients with regorafenib because I don't find toxicity is acceptable in these patients. So I tend to start lower and then build my way up.
So 80 or 120?
Usually 80 at our group, but obviously the dose per the package insert is 160.
Let me do a quick poll. I'm a 120er.
120.
160er.
So there you go.
So,
That's a perfect.
And I do think, you know, we learned with imatinib years ago, for example, patients, you can go up much easier than you can go down. And so, and of course, if you get a major toxicity early on, then you may be 3 weeks, 4 weeks before you can restart it. So I tend to start 80, we'll go up to 120.
So let me do the next poll. So if you start at 80, you see them when?
I see them, we see them we talk to them or see them weekly.
Squeaky clean at day 8. You escalating or
I'll
holding?
wait, if they're squeaky clean at day 15, I'll
Day
go
15
I'll
is
go
when
up.
you'd go up. Squeaky clean at 120, I'm holding.
Squeaky clean at day 8, yeah, holding.
Holding. Some minor stuff at day 8. You going down or are you going to keep with it?
So starting with 160.
Starting with 160.
Probably stick with it.
Stick with it. See him a week later. So Dave, still squeaky clean.
Then I'll start dose escalating.
For the last week?
And I might go as high up, if it's really squeaky clean, I might go to the full dose of 160.
For the last week of that
correct,
3-week
for that cycle.
All right, and so I probably am holding through the first 3 weeks at 120. I'm still seeing them, but they would have to, you know, maybe if it's really squeaky clean, when are you?
Next cycle.
Next cycle to day 1. Had a little hand foot, okay, little tenderness, but got better by cycle 2, day 1 at 160. You holding?
Well, you have to have a discussion with the patient. I mean, you know, it's all about quality of life. If the patient says, you know, it's reasonable, it's not affecting my daily, I'd go with it. If it seems to be affecting their daily living, I definitely would go down. And just to be clear, I don't disagree that the story with all these TKIs seem to be consistent with a dose escalation, de-escalation issue. The problem, so you brought imatinib. The imatinib and GIST, we're talking about 2-3 years. In this setting, we're talking about 2-month PFS. It's very difficult when you know that there's 20% of the patients who will need, I want to say will tolerate the 160. They may not need it, but will tolerate the 160. It's a little bit difficult for me to do the slow escalation when I know that I may lose benefit very quickly. But the key, I think, is to really see them as all of you do. See them really on a weekly basis, regardless of where you start.
I think it helps with compliance. The patient's engaged in what we're looking for. It's more time in discussion.
And the right dose, I mean, if you look at across the studies, the average dose is close to 120. So that seems to be the dose where most patients end up falling.
Weekly CBC and LFTs?
Yes.
And looking at those and make everybody agree with that. I just want to throw this out. Those patients that seem to fly through at 160 and no tox, I haven't seen a responder yet. The patients with some hand foot, and so anybody else seeing tox and benefit?
No, I can't say that toxicities, at least in my practice, has been limited to benefit, but I've seen patients go, I have actually had a patient go a whole year on 160.
And so benefiting on full dose.
So stable disease will drop in CEA.
Without tox.
You don't see the response.
Yeah.
Right now, and I would be honest. At our group, we tend to move towards phase 1 or earlier phase studies in these patients. I will often reserve regorafenib or TAZ for after a research protocol if we think there's one that's really promising.
Yeah. The one thing that's steering me away from that, because we all have that kind of center, is that, you know, the more they're looking at PS2 patients, that they really don't benefit from really either of these oral therapies. So I know we're all clinical research jocks, but are we on the other side leaving known survival benefit on the table because we're going for the shiny thing over in the corner?
And it may very well be. I'm the first to admit that I may be utilizing these drugs wrong because I tend to be shy about toxicity and don't dose intensely. that may be wrong, it's perfectly true. I think, though, when you see, if you come upon a new drug that has activity, you're reminded the value potentially of putting these patients on studies earlier and perhaps them getting benefit from that.
Tony, how are we going to figure out what the right dose is?
So we're about to complete a study, a readable study through our Accrue network that essentially randomized patients to two different strategies. One is the dose escalation with the 80 leading to 160 on a weekly basis as tolerated, and then the other is straight up 160. I'm hoping we'll have the results of the study presented somewhere in the fall of this year. Again, it may give us guidance about what strategy may be best. Perhaps it's the escalation strategy, and then, of course, that will change my practice and perhaps a lot of the other practices that start at 160, or maybe not.
Are you getting most of your patients through both of these drugs?
Rarely. I usually think we get one or the other into patients. It's a rare patient who I can dose with a genuine course of each.
Is that because of trials, or they run out of body?
I think they run out. They actually may run out of enthusiasm rather than anything else.
So I agree with that. It's unusual that I'm getting both in.
Yeah, same thing. Usually one in, but mine's a little bit more trial related because they're on something else.
Sometimes picking right is important. Tony?
Yeah, I think it's a 50% equation. I mean, half are not getting through both.
And why we have approved drugs with survival benefit, and yet we're leaving them on the table. Why are we doing that?
Well, that's a good question. I think part of the reason I might do that is I might go back to a drug that we used before. Remember, a lot of times we've moved beyond Folfox, not because of its lack of efficacy, but because maybe early neuropathy. If you're a year or two down the road and the neuropathy is gone, I might go back and re-challenge with oxaliplatin. In fact, I think we know the disease morphs over time. The pressure of treatment will change the genetics of the cancer. So we're tending to go back and revisit other therapies again, perhaps rather than TAZ or Rego, if those are the ones we haven't used, because we see that there may be upside and patients believe there may be more upside, especially with oxaliplatin, which if we've abandoned it because of toxicity, I will often go back to it later on because I think there may be still gas in the tank if we do that.
So for me, if I meant that, gave 6 cycles, no more than 8, it's been a couple of years, but I'm also thinking I'm going to get a response, but I have to tell you, I've lost enthusiasm for this. It's rare that I see that response. I don't know what you guys are seeing.
I've not seen that.
I think,
Johanna?
I think we see stable disease.
Yeah, but I'm getting stable disease with
Fair
these
enough.
too.
Sometimes stable disease, I think what it is a desperation move, right? We just want something so bad to give our patients, we'll try to find an excuse to re-challenge.
So is everybody's enthusiasm, I get where you are, and that's the card I'm playing, but my enthusiasm from a year ago is falling.
That's why we favor clinical trials because we're really looking for something else.
3 VEGF antibodies, switch them out? No.
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 No. 2 EGFR antibodies, switch them out? Are they different? I mean, in our neck of the woods, we only have one. Switch them out?
No.
Switch them out?
No.
If you've had one, you've had one.
You've had one, you've had them.
Very good. I think this has been a great discussion around refractory disease and how to manage it and all the different drugs.